Hi, I am Stephen Keteyian, and it's my pleasure today to present the primary results from the I-ATTEND trial, which looked at the effects of hybrid cardiac rehabilitation using a synchronized telehealth approach on patient attendance. I'd like to thank my co-investigators for this trial. This slide represents our disclosures that I wanted to convey. Okay, we know that less than 40% of the patients that participate in cardiac rehabilitation complete all 36 sessions. The number of cardiac rehabilitation sessions completed is important because it's directly associated with the magnitude of improvements that we get with clinical outcomes. By that I mean the more sessions attended, lower risk for rehospitalizations, lower risk for future mortality. Now, the reasons impacting attendance are many and include dependent care responsibilities, transportation issues, and both of these problems are accentuated in patients with Black race and in women. The primary aim of the I-ATTEND trial was to assess the effects of hybrid cardiac rehabilitation on overall patient attendance. If you look to the bottom of the slide, you can see here we're defining hybrid cardiac rehabilitation as an intervention that includes at least one facility-based cardiac rehabilitation session, and then up to 35 synchronized telehealth virtual cardiac rehabilitation visits. A patient could do 2, 3, 4 in facility, and then the rest, up to 36, in a telehealth setting. And on the right here, you can see a WebEx that we used for our platform, where the cardiac rehab staff person is on the left here, and the patients are exercising connected by WebEx. Our primary hypothesis was that the number of cardiac rehabilitation sessions completed within 6 months will be significantly greater in patients who used hybrid cardiac rehab versus patients who were randomized to facility-based only usual care cardiac rehab. We also had another important attendance-based hypothesis, and we also looked at the percentage of patients completing all 36 sessions in 6 months in the hybrid group compared to the facility-based group. Had a couple other secondary hypotheses. 2 of them surrounded exercise capacity. The first was based on the 6-minute walk distance. And our hypothesis here is that the improvement in exercise capacity, as measured by 6-minute walk, would be equivalent in both study groups. One group would not be greater than the other. The same thing for our second exercise capacity measure, which was peak oxygen uptake. Again, the improvement in exercise capacity, or the change in exercise capacity as measured by peak oxygen uptake, would be equivalent in both study groups. And then we had a quality of life outcome measure as a secondary outcome. We used the Dartmouth COOP total score, and we hypothesized that the improvement or change in the Dartmouth COOP total score would be equivalent in the 2 study groups. This is a busy slide, and let me direct you first here to the upper left. You can see that between March 2019, December 2022, we screened through our free cardiac rehabilitation orientation offered in Detroit, Livonia, and West Bloomfield, Michigan. 2,392 patients attended the orientation prior to potentially getting into cardiac rehabilitation. Of that, some patients were excluded from participating in the trial when we talked to them about it, about 1,300 patients for protocol-specific criteria. Another group stated to us, after being explained the trial option, that they simply didn't want to participate or had personal conflicts, another 700 or so people. There were 10 people who wanted to participate, consented, but were eventually not randomized due to certain conditions. Eventually, there are 282 patients that participated in the I-ATTEND trial, randomized 142 and 140 in hybrid versus facility-based. Now, a lot of these people that didn't participate in the trial got into cardiac rehabilitation. In fact, if you add up all the people that participated in cardiac rehabilitation, It was 1,970 people out of the 2,300 people that attended the orientation, or 82% went through cardiac rehab. The 282 people that participated in the trial and were in IA10 were 14%. With IA10, we had two primary assessments, one at baseline, where we measured our exercise capacity variables and our quality of life variables. And we repeated the assessments 6 months later or right after they completed cardiac rehab, whichever came first. Okay, in terms of results, 282 people randomized into the trial, average age about 60 years, 32% women, and we're very pleased to share that we had 53% Black race. These were the eligibility criteria for enrolling into cardiac rehabilitation, predominantly myocardial infarction. Very pleased we had over 20% of the population had a history of heart failure. Primary reason for enrolling in cardiac rehab was heart failure, coronary artery bypass surgery 11%, PCI 14%, and other. Overall, all patients, both groups, over 7,700 cardiac rehabilitation sessions were delivered, 4,000 in the HYCR group and 3,800 in the facility-based group. 67% of the hybrid cardiac rehabilitation sessions were conducted virtually. So 33% were conducted facility, the hybrid component. We had one non-fatal stroke within 3 hours after exercise. That was a patient in the hybrid cardiac rehab group. There were no virtual visits, no telehealth visits that required us to contact a physician for physician care level care. No mechanical falls in either study group requiring medical attention. Our primary endpoint was attendance. And as you can see here, total number of sessions completed in 6 months was 28 in facility-based and 29 in hybrid. No significant difference between the two groups. One of our first secondary outcome measures was the percentage of patients completing 36, 51% in the facility-based group, higher, 59% in the hybrid cardiac rehab group, but no statistical difference between the two. So in essence, we reject our primary outcome, or excuse me, our primary hypothesis that attendance would be greater is based on total number of sessions, six months. We reject our primary hypothesis based on our data. Our exercise capacity as secondary outcomes are shown here: oxygen uptake, exercise time on treadmill, 6-minute walk, and our quality of life, Dartmouth Coop total score. I draw your attention to these two columns. This is change from baseline in facility-based. Peak oxygen uptake went up 1.9 mLs per kg. In hybrid, went up 2.3. The difference between the two groups, 0.4 mL difference. The difference crossed over 0 based on the confidence interval, so not statistically different between the two groups. Exercise duration went up 1.7 minutes versus 1.9 minutes, difference 0.2, confidence interval crossed over 0, so no statistical difference between the two groups on the delta on the difference between the two. 6-minute walk went up 50 meters versus 46, 4-meter difference between the two groups, crossed over 0 based upon the 95% confidence interval, no statistical difference between the two groups. Quality of life or health status went down, which is a favorable change, 3.4 versus going down, 3.9. The delta is 0.5, crossed over 0 based upon the 95% confidence interval, so no statistical difference between groups. Our test for equivalence was done by a two one-sided t-test. Don't have enough time to explain it here, but we'll say that equivalence was determined based upon the TOAST test for all 4 variables. So by conclusion, and most important, standard facility-based cardiac rehabilitation and hybrid cardiac rehabilitation resulted in similar patient attendance patterns with no significant difference between groups. Standard facility-based cardiac rehabilitation and hybrid cardiac rehabilitation resulted in equivalent improvements in exercise capacity and health status. Our take-home message is hybrid CR should be considered as an acceptable alternative to facility-based CR. Thank you.